The problem is you do see a lot of antisocial people succeed. Loneliness is as big a risk factor for ill health and death.
We live inside our heads.
You go cold turkey, you go into withdrawal.
There is a lot of value in the stuff that we struggle with.
Better Thinking. Conversations with experts exploring all things psychology. Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Dr Genevieve Rayner. She is a practicing clinical neuropsychologist and lecturer in clinical neuropsychology at the Melbourne School of Psychological Sciences. As a clinician-scientist, she balances her clinical and academic work with her role as a senior neuropsychology research fellow in the world-leading Epilepsy Research Genetics Group at the Epilepsy Genetics Research Program. Her program of research aims to explore the neurobiological and psychosocial underpinnings of mood and cognitive disorders in epilepsy and other neurological conditions using behavioural, neuroimaging, and genetic methodologies. Genevieve is a member of the Next Generation Task Force of the International League Against Epilepsy, a founding member and secretary of the ILAE's Young Epilepsy section, and a member of the Research and Training Subcommittee of the Epilepsy Society of Australia. She is also a YES representative for the 13th Asian and Oceanic Epilepsy Congress Organising Committee. Today, we speak about epilepsy, its causes, its treatments, and its psychosocial considerations to think about, as epilepsy doesn't just affect the organic and biological side, but the whole person. And I can't think of anyone better than Genevieve to speak about this. So it was a great pleasure to speak with her, and I hope you enjoy today's episode. Genevieve, a big thank you for coming onto the show today. I am excited to talk to you about the world of epilepsy, but furthermore, looking at how the psychology of this condition might be affected through these psychological spaces of mood disorders, anxiety, and everything else, and also find out a little bit more about epilepsy, because I think it's a term that I've known of and I've heard and I've certainly observed experiences, but it's usually from a very distant space. I've never gone out and done a deep dive, so I'm eager to hear about all the research and your interest in it and find out more.
Oh, thank you for having me. I could talk endlessly about this topic. It's a huge passion of mine, so very pleased to share this with your listeners.
How did you get into the space of specifically looking at epilepsy? Because it's such a very narrow focus, and that's what attracts me to having these types of conversations, because you've obviously zoned in on something, and there's a great passion there. But how did that form?
It was an accident, I guess. I didn't go into psychology or neuropsychology with a specific with any preconceived notions around epilepsy. But once I started training in neuropsychology and learning around how the brain shapes our behavior and the way we think and act, epilepsy really jumped out as an exciting academic space to be in. It's a rare condition for a neuropsychologist that affects people of all ages. So it often has onset in children and is a lifelong condition. So that's an interesting space as a psychologist. We can support people over the lifespan. And it's also a relatively unusual condition, again, intellectually, in that in many types of epilepsy, only a small part of the brain is impacted or by the disease. And so that allows us to make connections between what that specific area of the brain does when a disease impacts it and the flow-on effects for behaviour. And the other so that's from an intellectual point of view, I guess, of what drew me to epilepsy. And then from a clinical point of view, epilepsy is again can be unusual for a neuropsychologist. A lot of people see a neuropsychologist, something bad has happened to their head or their brain. In epilepsy, and in my role particularly, I have a rare privilege of often my patients get well and return to a normal life, and helping them figure out who they are once they get well, and to help them achieve their goals is a very privileged space to work in as a neuropsychologist. So there's very interesting academic aspects, and then getting to work with people with epilepsy is a great privilege. They're a very generous patient population in terms of the time they give us, and always looking to help further the research into the condition. So it's just a fascinating space to work in.
And how what's the modern way of looking at epilepsy? Are we considering epilepsy a disease? Is it a condition? You've mentioned that it often the onset is in children, but can go through to a lifespan. Does it resolve? Specific treatments that do resolve it. I find it, although I've heard the term, as I said, never really gone into any detail to understand, what is it? It's kind of like MS. Most people don't know what MS is unless a family member has had it, and then we do a big research and like that's how we tend to learn. So can you talk me through what is considered epilepsy? We've all seen the features and the classic thing, and I'm sure it's still happening for lots of young people as well when they're first exposed to what epilepsy looks like, which is usually the air quotes having a epileptic seizure. That's the right word. I'm not sure if we still use that.
It can be a really terrifying diagnosis. There's a lot of misconceptions around what epilepsy is. As you say, the pop psychology notion of it is from the movies, someone falling down on the ground and having a big fit and, frothing at the mouth and all this. And although some seizures, generalized seizures that affect the whole brain at once may well present like that, they can be incredibly nuanced and hard to detect as well. So, for instance, in children, often certain types of seizures look like daydreaming. And so then, children are getting in trouble at school for tuning out and things like that. And actually, it's a type of seizure known as an absence seizure, where they really just kind of go offline and tune out for seconds to a minute or so. And then they sort of are back to reality. So diagnostically, I guess epilepsy is a disease that affects the networks in the brain. So the cause that causes then, I guess, electrical imbalances in the brain. So then that causes too much at a very basic level, too much electrical firing of the brain. Which then can either stay in a very small area of the brain where the seizure starts, which is known as a focal seizure, or it can spread very quickly and involve, both hemispheres of the brain, and more known as a generalized seizure. What causes these electrical and electrochemical imbalances ranges from person to person. For some people, it could be a tumor in the brain, or a lesion or head injury, something like that. It could be, in some cases, a genetic condition, not necessarily inherited, but a genetic mutation that might give rise to abnormalities in how the brain, forms, or how the brain signals to each other, the pathway signal to each other. Or it could be that, the brain forms structurally incorrectly. And for at least a third of people, we don't know what causes their seizures. So it is still somewhat of in some cases, a mysterious condition, but we've made huge strides in the last sort of, 20, 30 years around uncovering genetic bases for epilepsy, in developing new imaging so we can see lesions that we previously couldn't see. Because I guess understanding what causes the epilepsy, the seizures, and epilepsy being multiple seizures that aren't triggered by anything in particular, then once we understand what's potentially causing it for that individual, we've got a better chance of selecting the right treatment to deal with it. So it's very important to try and understand where they're coming from, even though it's not always possible.
So the generalized seizures are the ones that most people have been exposed to in terms of the media, and they're much more memorable. They affect both sides of the hemisphere of the brain, and therefore can have much more motor effects on motor movements, at least in that particular episode or seizure. But more commonly, it's a focal seizure, and it's harder to pick up that someone kind of like goes offline. If I'm not sure what languages I'm trying to pick up. Because I've never observed what a seizure might look like that's focal. How would someone know or start to consider that this might be occurring?
So I think I should know this, but I think actually generalized seizures are more common, but focal epilepsies are harder to treat. So we see them more in the hospital setting. Around 30% of people with focal epilepsies are going to struggle to be treated with medications. So yeah, what does a focal seizure look like? Well, like I said, that you can have it can range from very mild through to very obvious. So, if the seizure is contained to, for instance, the language area, the language networks of the brain, it might just be that they stop talking. And sometimes they might be able to follow commands, sometimes they might not be. They're just not aware, is how we term it. For other seizures, for instance, that affect the frontal lobes of the brain, they might have what's known as like a hyperkinetic seizure, where they jump up and down on the bed or, move kind of wildly. So being able to observe the seizure and how the seizure is unfolding, what the symptoms and signs are during the seizure, can actually give us clues as to where in the brain the electrical disturbance might be starting from. So that's known as the semiology of the seizure. So part of understanding in focal epilepsy where the seizure is coming from is we certainly use EEGs, which, the electrodes on the head to measure the brain activity underneath the skull, but also closely observing what the patient is actually doing during the seizure can be really illustrative for what brain regions are impacted.
So seizure can occur anywhere in the brain, and so the fact of having a seizure means that there's a higher electrical rate that somewhat is it's not a deliberate, it's kind of sporadic, does its thing depending on whether it remains focal or generalizes to much further into the brain. And if it's a focal one, you're just looking for signs of what's occurring so that you can understand where it at least starts to point in a direction where it might be occurring, because those signs are connected to certain regions of the brain.
Yes, exactly. And again, we're looking for, as a team, in an epilepsy team, we're looking always for consistent information. So is the EEG telling us that it's coming from this part of the brain? Is the behavior that they have during the seizure telling us it's coming from that part of the brain? And then as a neuropsychologist as well, we often get involved to examine their cognitive functioning in between the seizures to see if the effect of, having a lesion in the brain or the ongoing effect of seizures in that part of the brain impacts on how the patient can, remember or their language or their attentional function or whatever. So as a team in epilepsy, we're always just looking for concordant consistent information across different diagnostic tests and measures and things like that.
And what often happens after a seizure? Do we see a declining cognitive capacity? Do people report feeling exhausted, tired? I mean, when I think about it, and it's probably very clumsy, but to me, it feels like it somewhat is almost like a bit of an assault on the brain. I mean, maybe that's where the head trauma has some relationship with it in terms of triggering it. But I'm not sure if I'm going down the right track. Do we see reductions in cognitive capacity? Do we see disorientation? Do we see confusion? Do we see tiredness? Do we see mood differences? What? And I know it's individual, so but what are the general patterns that you've observed in your research and work?
Yeah. I think a lot of patients will feel exhausted afterwards, particularly if they have those big generalized seizures where, you know, every muscle in their body is involved. They talk about it being like they ran a marathon, that sort of thing. Their whole body hurts, like they've overdone it at the gym, that sort of thing, with those really big generalized seizures. But even the focal seizures really can take a lot out of someone. There's this really interesting, maybe it's a smidge gory, but, you know, back in the 1950s when we were when we were really first starting to operate on people with epilepsy and map the brain of people with and without epilepsy, there was a famous neurosurgeon, Wilder Penfield, and he was a forerunner in mapping the brain while patients were awake often, and we still do this. They'll put the patient to sleep, open up the skull, and then bring them up to a level of consciousness so we can talk to them, and then you basically zap different parts of the brain to stop it functioning for a few seconds, so then we can see what the function of that part of the brain is. So for instance, if you zap a bit and the person can't talk, well, we know, well, we better not operate and cut out that bit because it's obviously important for speech. So when he was pioneering this kind of treatment, he noticed that when some of the patients would have a seizure during the surgery, the area of the brain where the seizure was coming from would turn bright red. And that's because a seizure uses a huge amount of metabolic resources, be it glucose, oxygen in the brain. And so that was this huge rush of oxygenated blood rushing to the site to feed the seizure and to feed the brain at the site of the seizure. So even where in patients where they're not, you know, experiencing a full body fit, their brain and body is still using up a huge amount of metabolic resources. So a lot of people will still say that they feel really tired after a seizure. Some don't. Like some, I'll be in the middle of doing a cognitive test and they have a seizure, and I'll say, oh gosh, you know, let's take a break for the day, you know, you can come back another day, and they'll be like, no, I'm fine to keep going, you know, let's just do this. So it does vary, but I think for most people it's a pretty exhausting experience. Some people can get quite emotional afterwards, sometimes out of embarrassment, but also, you know, if the seizure has involved parts of the brain that regulate our emotions and our mood, it can be an organic kind of reaction. And then in some cases, you know, probably less than 10% of cases, well, in less than 10% of cases, I should say, you know, there is a phenomenon known as postictal psychosis, where some people will, particularly after a cluster of seizures, might develop sort of symptoms of psychosis for a couple of days. So that can be very scary.
And what would you say is the typical length of time that someone feels fatigued, you know, and has I suppose at least a conscious experience of they're tired? Is it usually a 24-hour period? I know that I'm sure it can vary immensely between individuals, but is there a most common report that you've heard?
I think after one of those big generalized seizures, for instance, a lot of people would take the next day off work or school. You know, probably longer if it's your first one, and that's a pretty frightening experience and you're not used to them, you might take longer off. But other people might just go home for the rest of the day and then be back the next day. It really, and like I said, then other people just keep on going, might have a sip of water and then feel okay. So yeah, it very much depends. But if you're working with someone with epilepsy, or I think it's the gracious thing to do is to give them the space to decide how long it's going to take them to recover and get back to their activities, because it really does vary hugely. And some people, as I say, it's like they've run a marathon. And I know if I ran a marathon, I wouldn't be up and about the next day. So, yeah.
And do generalized seizures still come from a focal area? Is there an understanding that happens on a focal sort of catalyst, so to speak, and then generalizes out? I suppose my question is, if it's focal, does it continue to be, rules of thumb, obviously, does it continue to go to the same focal places, generally speaking? If it is generalized, does it have a focal starting point? What do you generally most likely see?
Yeah, great question. So yes, all of the above.
All of the above.
For people with focal epilepsies, certainly for most of those people, their seizures will start from the same place every time, particularly if there's a lesion or some structural abnormality that's triggering the seizures. They will generally always start in the same area. Now, whereas for generalized epilepsy, definitionally you can't really tell where it starts because it just spread so quickly. However, you can kind of have a combo of the two. You can have focal epilepsy and then it spreads to involve the rest of the brain. So we might say in that case, that they're focal and then focal to bilateral, i.e. starting locally and then spreading to bilaterally both hemispheres of the brain. And then some people are unlucky enough to have, both types of seizures, where they might have some focal seizures, some generalized seizures, or focal seizures that start from different parts of the brain. And again, understanding that is important for treatment. The neurologists use different types of drugs to treat different types of epilepsy. And relevant to focal epilepsy, if the medications aren't really doing their thing, if as a team we can kind of narrow down that their seizures are coming from one particular part in the brain reliably, we may well be able to offer them epilepsy surgery, whereby if the medications aren't controlling it, the surgeons, my neurosurgical colleagues, can remove that part of the brain that we think the seizures are coming from. And that can be up to 80% successful, that those patients will not have another seizure after that. So for the most common cause of that type of epilepsy. So understanding where they're coming from and why they're coming from that particular part in the brain is a really important aspect of epilepsy care. And
that's I'm assuming for the 70% that we generally know where it's coming from, they're the scenarios where a tumor, or there's some sort of structural abnormality, or there's some sort of lesion. It's something that you could quite confidently point to and observe. I'm assuming that when you do your examinations, you can observe a repeat focal space, or even a region as to why it's forming from there, because you have found a lesion, or you have found a tumor, or you have found something that is the correlation is so high that it makes sense that to remove that would likely have a positive effect on reducing those electrical activity, sort of spontaneous occurrences occurring. And after removal, you're saying 80%, which is huge. That's a high number. Yeah,
it's very cool. It's very cool. So of the patients that do go for surgery where the medications don't really work, a lot of them do have something we can see on MRI, a structural lesion or damage, but not all of them. So increasingly we're operating also on patients where there's no structural abnormality. And instead, the reason we know the seizures are coming from that part of the brain is because of, for instance, other types of neuroimaging lineup. So when we give them a PET scan or a SPECT scan, we can see that that there are parts of the brain that are not metabolizing glucose, or they're using too much oxygen, suggesting that that's where the seizure is coming from. And if that aligns with what the EEG tells us about where the seizure is coming from, and if it aligns where the seizure behavior suggests the seizure is coming from, then we may well feel confident as a team to go forward with surgery. And then another innovation, I guess it's relatively new in Australia, the French have been doing it for ages, is a procedure known as stereo EEG. So in traditional EEG, the electrodes are on the skull, on the outside of the skull. In this type of EEG, the neurosurgeons actually drill holes into the skull and insert the electrodes directly into the brain tissue so that they can record electrical activity directly from the brain. And that gives us a really a much more accurate localization around where the seizures might be coming from. We're not just relying on an estimation at the scalp. You can get into the deepest parts of the brain with little electrodes and measure the activity from there. And so, for instance, that has really opened up the door to epilepsy surgery to people that previously we might have said, oh, we don't have enough information to go forward for surgery, but now using these depth electrodes and things like that, we can measure electrical abnormalities from deep inside the brain with great temporal resolution. It's very cool. Yeah.
This is extremely cool. I think maybe where I'm tripping over that I need your help with is when someone is having an EEG or PET scan or MRI, is there an understanding that the epilepsy condition is active all of the time, most of the time? Because in my mind, obviously looking at from the outside, I've seen it as someone has an episode, and let's say it's a generalized one that has affected their physical motor coordination. You can definitely see something's going on in that, and it's a lot higher than at any other given time. That immediately tells me that, hey, if we put them in a PET scan or a CAT scan or a MRI or an EEG or stereo EEG, it might not be active. So this is where I'm maybe getting confused. Is there, do we usually find that epilepsy is an ongoing active thing that can be measured most of the time? Is it all the time? Is it needs to be more present, so someone has to be kind of going through these episodes so that you can identify it? And then I want to definitely go back to the stereo EEG because that sounds wild. But can you help me out with that?
For sure. Yeah, sorry if I didn't make that clearer. So yeah, for a lot of people with epilepsy, let's take, I guess, the MRIs and things out of it, because 30% will have something on MRI that we can see, but most people with epilepsy don't. So what are we looking for when they're not having the seizure? Is the brain kind of a bit, firing abnormally all the time? Well, for some people with epilepsy, yes, it is, and some it's not. So in particular, if they figure out, what type of epilepsy you have, and the neurologists prescribe you anti-seizure medication, for a lot of people, when they then go on to have EEGs after that, if the drugs are doing their job, it may well be you don't see anything abnormal anymore because the anti-seizure medications have have corrected the imbalance that was causing the abnormal electrical discharge. For other people with, different types of epilepsy or more severe epilepsy, certainly there are abnormalities that you can see on the EEG all the time. And as a neuropsychologist as well, we, for the vast majority of our role, are testing people while they're not having seizures and examining the functioning of their brain in between the seizures. And we can definitely see the impact of the epilepsy, the disease itself, and of the seizures in between, the events, the seizures. So it is an illness where the disease is, for most people, being controlled in the background, and if the drugs are doing their job, you don't see seizures, and you may not even see anything on EEG. But that there can nonetheless, I guess, for other people, there is an ongoing, I guess, abnormality that you see. And, as I say, for the cognitive and the mood effects can certainly persist in between the seizures.
Mm-hmm, mm-hmm. And so if it wasn't being managed by anti-seizure medication, you would likely see much more abnormal electrical discharges.
Yes.
At least the frequency would be up, and hence why some will be reporting having much more than when they're being treated. But it's not necessarily always at least measurable. It might be occurring, but it's not measurable at the level that we're looking at, because there needs to be a certain amount of calorie usage to pick it up to say it's an abnormal amount, and so on and so forth. That's what you're generally looking for: how much oxygen is being consumed, or how much glucose is being consumed. You're kind of like, where is there a higher output going on that we wouldn't be expecting on, like, rest, someone just sitting there not being stimulated. But in actual fact, there's much more electrical discharge going on than we would expect.
For some cases, particularly if it's poorly controlled. And anti-seizure medications were only really invented, the first ones were from the very early from the 1800s, but they really only started being developed and used, properly in sort of the 1910s, I think, and then really from the 1950s, the development really took off. So until then, people with epilepsy really didn't have treatment options. And so we know from historical records that, if you don't treat the epilepsy and you just kind of let it run its course, for many people, the epilepsy will get worse over time and cause, cumulative effects on cognition and mood, is the sense we get from the historical records. It's hard to tell when things have been, documented, in the late 1800s and things, but there certainly does seem to be a case that if you weren't treating it and things like that, that the disease gets worse over time, and you would see those electrical discharges all the time.
Yeah, wow. I imagine there might be some of that data still available in countries where the medical system hasn't caught up, and not everyone's being treated because in a rural area, and et cetera. There might be.
It's an amazing point, because it is a real issue in epilepsy care globally, in that the massive burden of epilepsy disease is in third world and developing countries, where the epilepsy is caused by infectious kind of causes, malaria, AIDS, things like that can have, secondary effects on the brain. HIV, sorry, not AIDS. And that a lot of those people don't get adequate treatment. There's not the resources to treat them as they should be. And so, globally, the burden of disease in epilepsy is disproportionately located where there isn't sufficient care, and where stigma around the condition still exists as well. So we've got a long way to go as a global community to even the playing field for people with epilepsy.
And if it is found and treated early, which I'm assuming would be the case certainly in Australia for most regions, and most Australians have decent access to care. Do we what do we expect? I know there's, once again, great range, but on a general basis, is most epilepsy relatively well managed with medication alone? What's the rate of surgery? What are the other alternatives? How else do you treat it?
So yes, 70% of people will be treated with medication, and the medication will entirely treat their epilepsy, which is fabulous. For certain childhood epilepsies, they tend to grow out of them as well. They're sort of syndromes that are limited to childhood age as the brain's developing, which is great as well for those kids and their families.
And of the medication, 70%, sorry to jump in, is that usually for life? That we don't sort of try to wean off every 5 years, 10 years to see, is it kind of like you just stay on for life? Is that how it works?
It depends how. So we don't really say that the epilepsy's, well, in our team, we're not fond of saying the epilepsy gets cured per se.
Sure.
Just that the medications control the seizures. So if, somebody's 5-10 years with no seizures and they dislike being on the medications, they may well want to start reducing the medications to see how they go, and to see if they can, maybe remain on one low dose of medications. And some patients do wean off medications altogether. So that is certainly possible for some people, but for a lot of people with epilepsy, it's kind of accepted that they'll be on these medications for the rest of their life, hopefully at a relatively low dose as they can manage.
And you kind of wouldn't know unless you tested it. You'd have to wean off, which has some risk associated with it as well.
Absolutely. Driving being the main one that is most relevant to people. So if you have a seizure, you're not allowed to drive for at least a couple of months if it's unprovoked. So that's a huge, if people depend on driving, they may be very wary to even try to wean off, because they don't want to, potentially not be able to drive. Which is
and the functional cost is phenomenal, let alone the possibility of it being a very serious seizure, and you could potentially kill yourself, kill somebody else, all sorts of things. So I can understand that, the risk would be higher. So therefore, if you were to wean off, you'd probably want to be very considerate about how you drive for a period of time before you get some confidence that it's potentially resolved and does not require medical management or medication to keep it at bay.
And there are very strict guidelines in Australia about driving when you're weaning your medications and things like that. It's one of the times that I'm very glad not to be a neurologist and have to navigate all that with patients. I'll leave that to my medical colleagues, because it can get messy. So that is sort of the pros and cons of weaning off the medications. Some people really dislike being on medications. They say it makes them feel, sleepy or like a zombie, or they just don't feel well on them. Other treatments, the ketogenic diet is used for certain types of epilepsy if they don't respond to medications. And there's a very particular type of epilepsy, GLUT1 epilepsy, whereby they have a genetic mutation that means that glucose doesn't go across the blood-brain barrier. And so the brain struggles for proper energy to function. And so the ketogenic diet creates an alternative fuel source for the brain. When it starts to form ketones, the ketones can be used instead of glucose to feed the brain. So that diet is used. It's not very well tolerated in adults because it's pretty unpalatable. But for kids or for patients maybe with intellectual disabilities and the like, where other people are preparing and sort of overseeing their food, then that might be a way of managing the epilepsy. And there are other diets. We have a dietitian specifically on our team for this reason. She's fabulous. And then, as I've mentioned, epilepsy surgery for patients where the medications are not working. And then for other patients in the last 10, 15 years, I guess, there's increased access to neuromodulation devices. So vagal nerve stimulators, for instance, which are little devices that they implant, proximal to the brain, that when a seizure is building up and the electrical activity is building up and is going to cause a seizure, these devices can kind of give a little buzz to the brain to sort of try and circumvent the seizure starting. So I don't know the specifics of that, so I can't answer any further questions on how exactly that works. I should know, but yeah, that is another option in the toolkit that's increasingly being used for patients where all other options have kind of failed.
It's incredible. It sounds like there's, in actual fact, a lot that can be done, and if someone has epilepsy, there's a method toward how to approach each possible scenario depending on what their particular condition looks like and the effects that it has, but does require ongoing. It's a process. There's a team that needs to be involved, and a lot of, I'm assuming, trial and error to make it fit and unique and individualized, so that those electrical discharges can be moderated, managed, and someone can, I suppose, continue on with a functioning life where it's not either causing them many episodes, but more so the effects between those episodes, which I'd like to pick your brain about now, because this is kind of like the treatment and the what is. I'm assuming there's quite a lot of research and body of evidence around what epilepsy also means from a psychological perspective, from a social perspective, I'd like to certainly focus a little bit on that, wherever there's, I suppose, a cognitive load, demand, people feeling tired. I imagine it flows into like a lot of areas. No different. So we know that there's a strong link between being unwell and depression. We see this in old age. We certainly see this with sudden illnesses and the like. What does the research say? What has your experience said to you as well about the psychosocial effects of epilepsy?
Yeah. I think a place to start, because there's a lot. Epilepsy really can impact most aspects of people's life, like, as you say, like many chronic illnesses. I guess the difference with epilepsy being that it is a disease that impacts cognitive networks, so it isn't inherently has cognitive sequelae to it, but it's also an illness that even in 2024 is somewhat stigmatized. So historically, epilepsy has, historical records suggest that people with epilepsy for a long time were confined to the edges of society, in lunatic asylums, labelled as imbeciles and things like that. And there was really no good recognition that it was a neurological illness as opposed to mental illness, and mental illnesses weren't treated very well either. On top of that, because of some seizures are very bland, but some are frankly quite bizarre looking when they're going on, and with shouting and grunting and the movements, and it can be really distressing to see someone having a seizure. And so, there's also over the long term been, stigma and links with the supernatural and witchcraft and things like that with people with epilepsy. So, and that really even persisted until the early, the start of the 1900s. And, for instance, I have a patient and I had a patient, he when I saw him, he was only in his 50s, I think, and he was an incredibly intelligent man. And he had been schooled in special schools in Australia in the 1950s and 60s purely because he had epilepsy, not because of his intellectual functioning. So he was put in a school with very intellectually disabled students simply because he had epilepsy, and that was, as I say, 60 years ago or something like that. And to this day, patients will often talk about not telling friends, not telling employers in particular about their epilepsy because of an embarrassment around it or fear that they'll be discriminated against. And there is evidence that there's good reason for them to think that way, that they may well be discriminated against, or that they're more vulnerable to poor treatment from other people as a function of their epilepsy. So
it's certainly because there's so little known. I wouldn't say by any stretch of the imagination I've been interested in going in and looking at that space. So it tends to be one of those items that about it, whether you have an interest like yourself or a family member or a good friend or something. But outside of that, all you know is that, young kids had epileptic fits. And that's how it was discussed. That's the terminology. I don't know if it's kosher anymore, but that's just how it was said.
Yeah.
So, we've got a kid who had they had an epileptic fit. And everyone talks about the fit. No one talks about what happens afterwards. Well, we know where it comes from. No one knows that there's this electrical impulses, and that would actually be something that's very identifiable in terms of structural lesions, so on. I'm learning about this all at the moment. I can see that when there is so much that's unknown, it is scary. People go, well, that could be a problem. That's a liability. What does this all mean? All these inherent issues that, rather than taking the time to understand it, human beings, we make shortcuts. The heuristic of, unknown is bad.
Yes. And as you say, when you're seeing the snapshot of the most dramatic aspect of the illness, the most embarrassing often aspect of the illness for the person experiencing and dangerous, then it is a very sensationalist view people often have of it. And they project that onto the person, and the person with epilepsy internalizes that as well. So it can lead to deep feelings of shame and of a sense of, being defective. And, that with some of our patients, we really do spend time, getting to the root of that and trying to overcome it. And, that really does lead a lot of my research is looking at how the actual disease of epilepsy gives rise to depression and anxiety as well. Because for a long time, we've known for a very long time, since Hippocrates, in fact, that people with epilepsy are very prone to depression, anxiety, and mental health challenges. And for a long time, it was considered that was kind of a normal reaction, like that, oh, well, they've got this, very dramatic, embarrassing kind of, in some cases, neurological condition. Of course they're depressed, or they can't drive, or, they struggle to keep a job, or whatever it may be, as people with epilepsy often do struggle to go to work and school regularly if their seizures are poorly controlled. So, there was this kind of concept like, oh, yeah, it's just a reaction to this crappy life circumstance that has been imposed on them. No wonder they're depressed. There's certainly an element of that the challenges of living with epilepsy, the impact on your relationships, on your finances, on your autonomy and your independence is a huge one. Definitely impacts on your mood. But it's also, do you have seizures that involve mood regulating networks of the brain? Well, that's also a real risk factor, having cognitive difficulties, and not being able to remember, positive things as well as the negative things that have happened in your life can make you vulnerable to depression as well. So I said to you before we started recording that, I very much see as my role, I put the psych in neuropsychology, because traditionally neuropsychologists were very focused on just the cognitive aspect, but I really think we have a lot to add in patient care, in appreciating their mental health journey from a cognitive and neurological aspect as well. It helps take the burden, I think, off the patient, that it's their reaction to their circumstances. We can certainly work with that, but also it helps develop strategies that target, the cognitive symptoms that feed into depression and anxiety as well. So again, understanding what gives rise to their depression, anxiety, whatever it may be, helps us to design treatments that are going to be more effective, is my view anyway.
I can definitely see there being both aspects, where the epilepsy itself, from an organic perspective, if we know it's connected to fatigue, we also know that people who are fatigued are much more prone to depression. We've got less resources to be buoyant, to fight off, whether it's unhelpful thoughts or even to feel joy. It's harder to feel joy at the end of the day when you're tired, and then it is if you've been well rested. So I can see that there's very, very likely that biological, organic space of saying that epilepsy would have a factor equation of effect in that. Similarly, I think, as you say, the psych part and the neuropsych space, the psych part being, someone's shift in identity, for example, after it's, first occurs, and ongoing, or potentially the fear of it occurring again in a public place, or, as you say, exclusion of certain scenarios, driving, life opportunities. There's so many things that as we look at someone's psyche, that's an ongoing process, and needs to be treated, or treated is the wrong word, let me rephrase that, needs to be supported, understood, nurtured, cared for, embraced, to assist someone in making these transitions, because in many sense we are saying, you're absolutely right, there is an electrical pattern going on, and we can observe that, and that doesn't happen in most people, but that difference doesn't necessarily mean disordered. How do we understand what difference is, and how do we live with that difference, because it has some practical challenges and problems. Let's be realistic. There's problematic things about this, and how do we set our own expectations? How do we educate others? If we're afraid of it and we're hiding, we're doing avoidance, what's that going to project to others? And the thought prisons that we find ourselves in, because we're hiding, the fear response. There's so much, I think, that understanding epilepsy, particularly for someone helping others understand what it means, and I'm assuming people with epilepsy don't understand it. They're evolvingly figuring it out. It's changing. It's different when you're young to when you're, maybe starting to form romantic relationships. It's different when you're starting a job. It's different when the onset is in older age rather than younger age. That's the psych part, I suppose. So we're trying to understand it and be thoughtful, considered, clinically considered, is so important in I suppose the support. How we help that I've never even thought of until today.
Yeah, I think that's really incisive, and it speaks to a lot of the research, that I've done with my PhD supervisor back, Professor Sarah Wilson, and a colleague of mine, Honor Coleman, and a lot of the work that we've done together is around exactly that, the impact of epilepsy on into how they integrate epilepsy into their sense of self. And you're totally on the money that, given that epilepsy is a disorder that has onset often in childhood and adolescence, which is when we're really figuring out who we are as people, it can have massive impacts on how people perceive themselves. And, and the degree to which they integrate the epilepsy as a part of who they are. And so some work, for instance, that I did with Sarah Wilson was looking at exactly how they do that. And it was this really interesting kind of finding in that the people with epilepsy kind of split into two groups. Those who integrated the epilepsy very much into who they were as a person, and those same people viewed the epilepsy quite optimistically. And they had an optimistic view of themselves and their epilepsy and their ability to cope with their epilepsy. They endorse statements like, epilepsy is a part of who I am. I tell people about my epilepsy. My epilepsy opens me up to new experiences and things like that. And those people had much lower rates of depression and anxiety over the long term. And, they seemed really able to face the challenges of epilepsy with aplomb. In contrast, people who felt very shamed by their epilepsy, who were very clear that the epilepsy was not a part of who they were and who they were in the world, who hid their epilepsy from other people, were much more likely, as I say, to be depressed and anxious. So it really spoke to us around the value of working with our patients with epilepsy to in some ways, and it wouldn't work for everyone, but to integrate a healthy concept of their epilepsy into their identity. Because even if they go on to have epilepsy surgery and, for all intents and purposes, get rid of the seizures, the ones that are saying, yes, I don't have the seizures, but I'll always be a person with epilepsy, and that's okay, are the ones that do well over the long term. So it's around working with people to minimize the sense of shame around their epilepsy and to open them up to new, more optimistic, I guess, without it being, from an ACT perspective, we always acknowledge that epilepsy is a shitty condition to be diagnosed with. Nobody's sugarcoating that. But how do they want to live their life in spite of having this disease? And it's a really valuable part of the work that we do, is going on that journey with people and, what do they want their life to look like? And yeah, these seizures might hold them back in some regards, but how can we get to those goals in spite of the seizures? And developing that mindset and that resilience mindset of almost like an exposure therapy, around exposing them to situations that you would maybe fear around having a seizure in, or they might have avoided, but that bring them joy, building joy back into their life and, challenging the concepts for them that the epilepsy is what's holding them back from living their best life.
It's interesting, particularly around those young ages. It's quite a challenge anyway. Period. We question everything at that age.
Yeah.
What's my hair look like? My lips the right shape? How big's my nose? Are my eyes the right color? And how far are my ears sticking out? And I imagine it's a lot easier to reconcile all of these things, when someone's 40, 50, 60, because we've dropped so much of that. But when it happens in the middle of, trying to form an identity, and then there's something which, jumps out, which says, because of this part of you, you're defective. The whole is defective, versus parts work of saying, there's a part of you that you're experiencing this, and that's part of your day or part of your week or part of your month. rather than taking over the entire whole. You know, there's still a person there, and then there's all the experiences that the person has. And I can see how those that are able to work on that, or they have a temperament around that, where they can be more accepting, or potentially even get to a point where they can be lighthearted, you know, maybe playful with it and laugh at it and go, oh, it's one of those moments again.
Yeah.
So they're not wrestling, they're not fighting, they're not in a tug of war with something they can't control.
Yeah.
No, we can control what medication we take, but we can't control how effective it is.
Yeah.
We can go out and get a test, but we can't assume that it will come up with something that is going to identify it. You know, you can get surgery, but you might not be part of that 80% that has positive. And even if you are, positive might not mean 100% removal. It might be there's a percentage reduction, and we call that positive.
Yeah.
But that identity stuff, I can see would play a huge role, particularly for younger persons.
Yeah, and a huge role for psychology in working with people to develop a positive identity around it. 100%. Yeah.
And is that where a decent portion of the research is saying helping people with epilepsy is the transition, the adjustment, the identity, which has a modulating effect around whether someone's presenting with depression or anxiety mixed, that epilepsy often at least has a bearing on that part of their life.
Yeah, I think it's a space that we're desperately trying to work on and flesh out. It has been sort of neglected, except for in the specific instance around epilepsy surgery. There is a lot of research around this issue, but on the flip side, so it's really interesting. So my supervisor, Professor Sarah Wilson, she worked with a neurologist, Dr. Peter Bladen, and they noticed and documented this syndrome after epilepsy surgery when the patients become well, their seizures are reduced or they're seizure free for the first time maybe in decades, that a lot of people struggle to become well. So to lose the identity, the epilepsy from their identity, and how do we best, while some people are like, you know, my life's just beginning and partying, maybe even overdoing it, you know, other people really struggle to let go of the sick role that they've made the epilepsy such a deep part of who they are. It's a wrench to let it go, which is really paradoxical. And before surgery, they all say, no, that won't be me, but nonetheless, some do. So there has been quite a lot of work around that and supporting patients, like a rehabilitation after epilepsy, a psychological rehabilitation after epilepsy surgery, to how they live their life without the epilepsy now. But there's certainly, you know, a massive need for more research around treatments for epilepsy that acknowledge the cognitive limitations of a lot of people have around memory and things like that, and also empowering psychologists to feel comfortable treating people with neurological conditions and epilepsy. A lot of our patients will, if we refer to the community psychologists, you know, we get requests from the community psychologist for consultation around, how do I treat this person? I've never treated anyone with epilepsy, you know, as we were speaking about earlier, like almost like a professional stigma, not that they're scared of the person with epilepsy, but it's such an unknown to them that they don't know where to start. And how do I treat this person? And actually the principles, of course, of, you know, once you've got an appreciation of the neurology and the neuropsychology of the condition, it's just like treating many other cases of depression and anxiety or whatever. So I think also empowering our psychology and neuropsychology community to provide these treatments for these patients is a huge next step as well.
I can see as well that interesting space of, when treated well, whether it's through surgery or a fantastic result from medication, particularly if it wasn't treated well previously, and then it's kind of having that profound effect. How that can still bring about a sense of loss. There can be a familiarity with a part of yourself that when is lost, it kind of questions, well, then what's left? Who am I without that?
Yes.
It can even raise even more complicated things like it's actually protected me against doing things that I didn't want to do previously. And
100%.
now that's scary. Now I don't have something to point to that prevents me from doing that. So I can see there's all sorts of complicated ways that are very genuine and difficult and entangled that
and the expectations others put on us as on the patients as well, like, okay, well, you're well now, so off you go back to work, or now's my time to shine. I've been looking after you. There's actually quite a high rate of relationship breakdown after these procedures, relatively speaking, just because the roles in the family change so much, and it can be that the partner got such a sense of their sense of self of being a carer to the person with epilepsy, and if that's taken away from them, like the ripple effects, within the person's family and community, because it's such a long-standing, entrenched condition, are just huge. It's just huge,
Genevieve, where can people find out more? Where do we go to continue this conversation? Are there particular books that you could recommend, websites? Are there institutions around Australia or abroad that you might recommend? I think there's a lot of people out there that either are affected by epilepsy or will be affected by epilepsy, both individuals but also loved ones, carers, friends, family. I think it's important that we encourage people to have these types of conversations and not shy away from them, removing stigma. This is no different to, at least in my eyes, any other condition that all human beings live with. We're born and there's a lot of pain and hurt and suffering and sadness, and we're trying to mitigate at least the suffering part as much as possible. So where can we go to find out more?
Great question. So I think if you're looking to learn more about the basics of epilepsy, there's the global Organisation for Research and Care of People with Epilepsy is the International League Against Epilepsy. They have a great resource called epilepsydiagnosis.org, that's for that will talk you through different aspects of epilepsy. We also have pretty fabulous epileptology in Australia. We really bat above our average in terms of our contribution to global epilepsy research. And so the Epilepsy Society of Australia has a fabulous series of webinars as well, including by psychologists, a couple by psychologists, as well as many by neurologists, around the neurological, the psychosocial, and the psychological aspects of living with epilepsy. And then I guess for peer support and for things like that, there's a lot of fabulous patient-run social media sites and things like that. So the Epilepsy Foundation, the Epilepsy the Epilepsy Foundation and Epilepsy Action Australia locally are great resources for those living with the condition as well. And then, I'm at the University of Melbourne, so Genevieve Rayner, feel free to Google me and reach out as well if there's any professional or people wanting a bit of support navigating where to, can be tricky. So if I can help, I'm always happy to as well.
Thank you for that. Great resources. And before I let you go, where do you hope this research goes to that you see in your lifetime, and whether it's your contributions and continuing to be in this space and others, your colleagues, what do you hope to see in the next 10, let's call it even 20 years? Where do you think we'll get to?
Well, The motto, I guess, of the International League Against Epilepsy is to try and create a world where nobody's life is limited by their epilepsy. And I think working towards that from a psychological perspective in, developing very patient-centered treatments with our patients as collaborators to develop these new ways of approaching epilepsy and acknowledging the contribution of the cognitive and the neurological. If we can get to new tools that are practical, I think that would be a fabulous goal.
I like it, epilepsy, limitless. That they come together, as I'd like to think many things are, and we are moving out of space, particularly around the psychosocial stuff. There's obviously practical physical things that might only have a limit of possibilities, at least today. But on the psychosocial, I think we've got some work to do, but I think some amazing work has already been done. I have to say thank you, Genevieve, for taking me through, from the very basics to some of the more interesting. At least for me, I have, and I'm sure I'm speaking for listeners as well, I've learned an enormous amount, and I can say that because I think I've been quite naive to this space. So I appreciate, the likes of your work and your contributions. We need to talk about this much more. And I wish you the best in your ongoing research and continuing to help, because I think what you're doing is remarkable.
Oh, thank you so much. And thank you for giving a platform for epilepsy. It's wonderful.